Good evening, everybody. How are you? I'm going to go over, again, the exchanges just in a brief detail. They're supposed to come out January 2014. If you are working for a company, a model notice was supposed to be handed out to you back in March from HHS. However, that has not been approved, so everything's kind of been pushed back. They say that the next model notice that hopefully will be given before the exchanges open will be in July, but now they're saying that they don't think they're going to be ready in July either. So we'll see if the notices are due to come out. Open enrollment for these exchanges will be October 1st for a January 1st, 2014 effective date. And as Chris was touching on, you'll have various levels, which would be bronze, silver, gold, and platinum. And what we've heard so far, what I've seen, are the carriers that are participating are the carriers that we know today, the United or the Oxford or the HIP or the Aetnas. However, it appears that they are going to consolidate their networks, so it won't be the same network that you might have today with your employer. It will be a limited network of doctors, and due to this law, what you're seeing now also with plans on the employer side is that you will have plans that will say, okay, if you see this doctor, it's going to be called a premium designated doctor. Your copay might be less based on quality of care and cost of care. But if you see the doctor, another doctor that you just may want to see that's in the network, you might pay a higher copay. So you're going to see a different type of network both in the exchange as well as in your individual or employer group plans. It appears that the federal exchanges that are out, and that's not New York, may not be ready till the end of 2015 or possibly 2016. There's a lot of details that go into it. If you are an employer with over 50 employees, and someone goes to the exchange and they need a subsidy, there's a lot of talk between the employer and the employee and the state to figure out if they qualify for subsidies. They're going to be digging a lot into the background. It's a lot of go-between, so I don't know how logistically they're going to be able to do it by 2014. The hope is that it does come out 2014, but it doesn't. We're not, I guess, that hopeful that that'll happen at that time. Okay, coverage expansion. There are some good things that came out of healthcare reform. Some of it in New York was already in place, to be quite honest, but in the other states it wasn't. And elimination of pre-existing condition exclusion, that will come into place next year for everybody, and right now it is in place for anyone 19 and younger. So what that means is that if you have a pre-existing condition and you don't have any coverage, you can now go on a plan right away without any health questions. That's a good thing, and it's not so good thing. In Massachusetts right now they have that, and what's happening with the carriers is that they're losing a lot of money because someone will pay the fine, the $95, because they don't want to buy health insurance, and then they need, God forbid, a gallbladder removed. So they'll go on to the plan quick, pay the premium. The insurance company pays out $100,000 of a claim, and then they jump off again. So that's the problem with the pre-existing condition clause. Right now in New York, we have a lenient one compared to other states. I used to work in Virginia and DC and sell insurance as well. It's much more stringent on pre-existing conditions, but in New York, as long as you've been covered with no lapse for 60 days, you can come right on the plan and not have any pre-existing conditions. So in New York, a lot of this was in place. Dependents covered to age 26. That came out of the law, and in New York you can also be covered, dependents can be covered to age 29 on a post-tax basis. So what would happen is if you have a child, even if they're married and living in another state, they can come on your plan at 27, 28, or 29 and pay the individual rate on a post-tax basis. Okay, preventative care services for women. Again, in New York, a lot of this was already in play, but women can go to the OBGYN once every 6 months for free, no copay for a pap smear. And they also get an annual physical for free at the internist or general practitioner. And men also get a free physical, but you don't see that there. That's just something that happens in New York. No annual limits on medical plans. Again, that was already in place here. So there's no annual limit, so God forbid you ran up $2 million of claims, they wouldn't cut the coverage here in New York on a fully insured basis. No co-payments for well care, so that's for children up to age 19. All their shots and well visits are covered at no charge. Again, in New York, we have that already. And no rescission of coverage, so they can't deny the coverage. Now, there's no limits on essential health benefits. So essential health benefits under the law is the ambulatory care, emergency services, hospitalization, newborn, mental health, substance abuse, rehabilitation. So there's no limits. You used to see in some of the plans 30 visits max, 20 visits max. That has been eliminated with the new law. Administrative requirements. So this is if, again, you're on a group plan. So what's going to happen in 2014, it's going to be a 90-day max waiting period for coverage. So if you're with an employer and you start, and they used to have first of the month following 90 days or a 120-day wait, it's a hard 90 days now. Many of my groups are going for first of the month following 60 days, just for administrative purposes. But now it will be a 90-day max. The again, the creation and notification of health insurance exchanges. So what the employers will have to do is once that notice is approved by HHS, they will have to notify all of their employees of the exchanges and how they work, and that they are eligible to go to the exchange if they wanted to purchase care. There's also, it's not on here, an SBC now. It's called a summary benefit comparison. So what happens is within the 60 days of you enrolling in your new plan, you will get a new format of your benefits. And what this was meant to do, and it's got to be 7 pages, and the font has to be a certain font, and the government's telling you, how to distribute this and what it has to look like. But it really is meant for, so if you want to shop coverage, if you want to take your current plan and then go on the exchange will have that same format. So it'll be easy to follow. So once a copay here will be exactly a copay on the same page. So you will be getting new SBCs, they're called. Medical loss ratio rebate. This started last year. It basically, the government is saying that if an insurance company makes more than 85%, or actually if 85% of the dollars of premium dollars collected are not spent on claims, the employers must get a rebate. So a lot of my employers last year, their claims were running well versus premium, and they got rebate checks back from the insurance companies. And they did like that. Employers share in the rebate. So if there's a contribution of 70% and 30%, the employer has to distribute that rebate accordingly. So they would keep the 70 and they would distribute to all of their employees 30%. If they didn't distribute it, they're allowed to use it for wellness or enhancements of the plan. Another administrative requirement is employers must provide access to coverage that is affordable and minimum value. So what I've been doing for my clients is I'm analyzing their plan, and what the health care bill says is that the employer coverage or health care coverage must pay at least 60% of the claims of the bills for individuals. If the coverage fails, they will have a penalty. So they must offer one plan that passes, it's called pay or play, that passes this minimum value test. And that means that 60% of the claim dollars are paid by the plan. The affordability is that the company now has to make sure that the contributions to each employee don't exceed 9.5% of their household income. So if you are paying more than 9.5% of your household income for the lowest plan option, your plan fails the affordability test, and then you can go to the exchange and the employer would pay a penalty. The summary of benefits, that's the SBC that I had just spoke about, that must be distributed. And for employers with 200 or more full-time employees, there will be automatic enrollment like you see in some 401ks now. So you will be automatically enrolled in your employer's plan if there's 200 and more employees, and you have the option to waive out. You will be automatically enrolled in the lowest plan option unless you tell them otherwise. W-2 reporting, again, this is for larger employers. On your W-2, you will see if you're working for a company, again, with over 250 W-2s that were dispersed, you will see the total cost of your medical benefits as a line item now. Okay? What that says to me, or to a lot of people, is eventually that will be a taxable item as income. Okay? So what Obamacare is requiring is that for any company that distributes over 250 W-2s, they will be required to report that, the total cost of the medical premium on your W-2 now. Right now, again, it's not being taxed, but it's there. One of the fees that's coming down is this patient-centered outcome research fee. And this is for, the government is saying this is to pay for research. And it's $1 per covered life per year in 2013. So that means what happens on the plan is for you, your spouse, your children, your employer must pay now $1 annually for each person on the plan, not employee. And it will go up to $2 per covered life in 2014, and that will continue to increase in 2019. So if you're a fully insured plan, the carrier pays for that, United or the Oxfords or the Aetnas. However, in all the renewals I've seen, they're obviously passing it down to us, the groups. So what they're doing is they're calculating all the members on the plan, not the employees, and they're adding $1 or $2 per person on the plan to the rate. Okay. The other fee that's part of the law is this transitional reinsurance contribution fee. This is to stabilize the influx of the newly insured people. So it's for the exchange. It's basically to pay for all of these people that they think will come onto the exchange with pre-existing conditions. And that fee is an estimate of $63 per covered life. So again, for the employee, for their spouse, for the dependents, now your employer has to pay $63, $63, $63, $63 for all of these members of their plan. So that's another reason why you're seeing probably larger increases. Then there's a health insurer fee to subsidize the expansion of Medicaid. And that's about this year, it says between 2 and 2.5. It's roughly about 2.3% in 2014. And that's going to continue to rise to 3 and 4%. And that's basically because they're expanding Medicaid. I think it's about 400% of poverty level. So if you're making about $46,000 a year, depending on, then you would be eligible for Medicaid. And again, that is being paid by the group plans. It'll be paid by the health carrier, but again, these are in all my renewals now. So it's being passed on to the employer, and the employer is going to either pass it on or split it, or I'll tell you what else they're doing in a few minutes. There's also going to be a potential penalty for Cadillac plans. And what that means is the law is stating that if your plan exceeds $850 for a single in premium, you will be taxed on that. It's too good of a plan. So what the government is saying is that if you want this type of plan, you're going to pay taxes on that plan. How is the marketplace reacting? I will say that a vast majority of the employers are still going to continue to offer medical coverage. They see the benefit in it for retention, to attract good employees, but they are reviewing options to reduce cost. One is what I've seen a lot because of those fees I just went into, the $63, the 2%, the $1 that's going to continue to grow every year, is that under healthcare reform, spouses are not considered dependents. Why, I don't know, but that's how the law was written. So a spouse is not considered a dependent. So what I see a lot of employers doing now is they're saying if your spouse has coverage elsewhere but chooses to take ours, including Medicare or a retiree plan, they are not eligible for our plan anymore. So they will have to go ahead and take Medicare or take their employer's plan. Okay? Or they're saying, okay, if they want to take our plan, they will pay a surcharge to try to pay for some of these taxes and fees that the government has imposed on them. So if your spouse has coverage elsewhere, but still wants to go on your plan, some of the employers are saying, okay, you will have a surcharge of an extra dollar amount per month to allow your spouse to be on the plan. It's not a fun thing to do. Okay. How is the marketplace reacting? Doctor shortages. What I'm seeing is there's going to be a lot of, they're saying that doctor shortages are definitely something to think about, that's a very possible outcome of what this law is about. Also, you're going to see a lot of nurse practitioners instead, maybe, of your doctor, or you're going to see those MediClinics pop up, those CVS Minute Clinics, and Walgreens is getting into that. So you're going to see a lot of those Minute Clinics pop up rather than going to see your doctor. There's definitely going to be a shortage of primary doctors from what I've been reading. How is the marketplace reacting? We can go to the next.
That's the last one.
Yeah. Well, before I get into that, I want to say something about the exchanges. When the exchanges do come, what they have is, as we said, it's the bronze, silver, gold, and platinum plans. And they're estimating that an average family going on the bronze plan with a deductible of maybe $3,000 a single, $6,000 a family before anything's covered, will cost about $20,000 to $22,000 for that family for the year. There was a 61-page application, and they say it's harder than doing your taxes. Now they're saying, now because there was such an outrage on this application that went around to our industry, supposedly they cut it down to 3 pages. So they went from 61 to 3 in a very small amount of time, which hopefully that will work. There's going to be navigators that will be answering your questions. The broker community, like myself, was trying to at least be able to help consumers to navigate through, and I think they just approved that. So if we enroll as of August, brokers who are actually licensed can answer questions rather than just having the navigators on the phone that aren't licensed to sell the insurance. Also, the IRS has hired 16,000 auditors. So what they're doing is they are making sure, so if someone goes from an employer and tries to get a subsidy, they are going to ask a lot of questions, tax questions and personal questions and income questions. And if something doesn't go right, both the employer and the employee could be subject to an audit, basically, is what they're telling us in our meetings, because they did hire 16,000 auditors just to police this law and to make sure that everyone is getting the benefits that they should be getting or qualified for. We'll see how that plays out. The marketplace reacting. And they're saying it's easier to apply for a green card than Obamacare, and that was where the application was 61 pages of instructions, but hopefully now it's down to 3. They've listened to us. I just said that the plan will be a cost of about $20,000 to $22,000 per family. That was the estimate they gave. Hopefully that won't come to pass, but that was the example that they gave from the bronze plan and the cost for a family. And I think you've seen in the news that some of the Democrats that helped write the bill are saying that it's, there's so many moving parts that hopefully we can get it together by 2014. If not, they probably will push it back to 2015. There are a lot of good things in this bill, as we went over the preventative care and the well visits for children and the access to care. But hopefully, all the moving parts will come together to implement this. And really, that's what I have.
Good evening, ladies and gentlemen. Thank you for coming. I'm Brian Malone, the chief pharmacist at Winthrop. I've been there for 32 years. With 5 children, I used to moonlight at local pharmacies where I grew up. So I'm kind of familiar with what happens on the outside with prescription drugs and the cost of them going up exponentially. Okay. As Dr. Capozzi said, the Medicare part that covers medications is not new. President Bush put that in 2003. Okay. President Obama put a committee together to change it, so I'm going to be going over some of those highlights now. I saw we had a fair amount of people that are less than 65, so I'm glad I put this in my slides because I was debating whether I should or not. But just quickly, the ABCs of Medicare. Part A covers hospital care. Okay. Part B is physician services and outpatient care. Part C is kind of a combination. It covers Part A, Part B, and part of Part D, so it's the Medicare Advantage plan. Okay. But I'm here tonight to talk about Part D, and that helps to pay for outpatient prescription drugs. Okay. And there was a lot of debate about this because on both sides of the aisle, they knew it was going to cost money. But at the same time, although I'm a conservative when it comes to taxes and costs, we did everything very well with the Medicare in terms of coverage, but yet we know drugs produce positive outcomes and increase quality of life. And I was kind of glad they put this into effect to help seniors out that didn't have money to pay for it. Okay. Those people that don't take the medications or aren't compliant with it are the ones that wind up back in the hospital. Okay. So there's two different types, but I'm going to focus on Medicare Part D, the standalone coverage. And basically, if you have a Medicare card, you can voluntarily apply for Part D coverage for your drugs. It's not a mandate. And the way that works is you can get on the Medicare.gov website, and you have a variety of choices. And that's where it becomes complicated. There's too many choices. It's like going to go buy a DVD player. You say, oh, geez, what am I buying here? Why can't there just be one or two choices? And basically the difference is the premiums and sometimes the deductible and the copays differ. There's no free lunch here. So basically, if you have very expensive drugs you're on, brand name, to cover those drugs, it's going to cost you more money per month, perhaps a larger deductible and a larger copay. So I'll give you some examples, just some tips. For instance, with my dad, he was on a very inexpensive water pill and a beta blocker for his blood pressure. He could get a 90-day supply for $4 on one and $6 for another. So he said to me, why do I even need this coverage? Because any place I look on the website or talk to Medicare, I got to pay about $30 a month premium. I have a $325 deductible, and I'm only on 2 drugs that are pennies. It's a gamble, but a lot of people do that because the good news is most of the patents expired on some of these good drugs we have today. You know, the patent of a drug is about 17 years from the time they start studying it. It takes about 10 years to get to the marketplace if it does. So basically you have about 5 or 7 years left on the patent. And most of those patents have expired, so antibiotics, water pills, different types of blood pressure medications, different types of pain management. Most of those are generic now, which literally can be pennies. So that's kind of the good news, that you can actually pick one of these plans, and based on the cost of the drugs, you can get the lowest deductible, maybe the lowest copay. And even when you're in that so-called gap, which we'll talk about in a little while, there won't be a lot of money outlay. Okay? So who's eligible for Part D? Basically, it's for people 65 and older, and there are some exceptions with people with disabilities. Okay? It varies by plan, as I said before, based on the cost of the drug, and it also is dependent on your income. If you make a decent salary as a retiree and you're getting like $170 a year between you and your spouse, there's an added charge on that, on the average $30 copay. Once you spend a certain out-of-pocket money, okay, you hit what they call a donut hole. And for you people that are under 65, you may not know what that is, but basically there's a gap where the coverage stops, and then you have to pay 100% of the cost of the drugs until you get to the other side of the donut, and then the insurance company starts picking up again, and you're paying co-insurances or co-pays, depending on what type of plan. The good thing about the plan, I guess, the Obamacare, is that donut hole, or that gap, actually shrinks, and you pay less for those drugs during that donut hole. So that's actually a positive. What can help you? If you go to the website, and you're pretty good with computers and you can navigate around it, the Medicare.gov has a lot of frequently asked questions. They actually wrote that pretty well compared to the law. You can actually understand most of it. Okay? And also, for people that don't have computers or aren't computer literate, I actually called for my dad recently, the 1-800 number here. I couldn't believe it. I had a 3-minute wait, and I actually had someone that knew what they were talking about on the end of the phone. What are some of the changes? Well, a couple of years ago, if you were on this plan, you may have saw that even if you went $1 into the donut hole, you got a $250 check in the mail. I remember my father thinking he was rich. I got $250 for doing what? He went into the donut hole, and you got the $250. That's gone away. That's not there anymore. Okay? As time goes on between now and 2020, you'll see the donut hole when you have no coverage at all. Okay? The percentage you pay for brand name drugs and generic drugs goes down, and that's where you're shrinking the donut hole, and you have less outlay of money. So from 2012, where you paid 50% for brand names, it's going down to 25%. And for generic, from 86 down to 25%. And just let me clarify this. This is for medications that plan that you chose, okay, has an affiliation with the drug company. The drug company's in on this too, right? They don't want to lose out on some of their brand name drugs, right? Because the generic industry's taken over. So they actually negotiated with the insurance companies that, gee, if I have certain tiers in the formulary where if the doctor prescribes my drug, I'm willing to give large percentages to help people during that donut hole. And the same thing with generic drugs. So that's built into that donut hole to shrink the amount of money, shrink the out-of-pocket money for seniors. Some people will tell me, gee, you know, I thought that was covered, but I went to the pharmacy and that computerized bill, I still had to pay top dollar for it, but it was a new brand name blood pressure medication. In that case, you got to talk to your pharmacist and say, listen, I don't know why my doctor, you know, gave me this new novel, you know, beta blocker, but is there something else I can get that's covered? And the company negotiated with this. And again, the good news is most of the generic drugs, which are very inexpensive, are on these plans. The only thing about it, no disrespect to physicians, got a couple of my kids married to them, they don't know a lot about the economics of medications. They prescribe them all the time, and they often don't know. The latest salesman doesn't always tell them that it's $6 or $7 a capsule or tablet. So they prescribe them not thinking of the economics of the situation. And doctors getting better in that. We're educating them now. But like I said before, you can treat almost every chronic illness now with a generic drug. So when you go to the pharmacy for your renewals, you should be asking them, I'm going to my doctor tomorrow to get renewals. Is there anything I'm taking now that has a generic equivalent or something within that family of drugs where I can switch to? Because some people are very intolerant to certain medications, so it's not that easy sometimes. But you can very cost-effectively treat almost everything now. Okay, as far as I think you talked about physicians before. My two daughters are physician assistants, and they're getting a lot of offers from these walk-in clinics now because if you look at the return on investment for a physician who goes through 8 years of school, 3, 4, 5-year residency, or more maybe, and to make an average of 150 grand as an intern is 180,000, 15, 16 years later. We used to ask my brother-in-law, when are you going to make your first dollar as a cardiologist? He does okay now, but you're going to see a lot more physician assistants and nurse practitioners because people aren't going to want to go into medicine. It takes too long to reap your investment. Okay, so we talked about the pharmacists helping you out and what drugs are covered or not covered. And if it's not covered, we can call the provider for you and get an alternative. This is just a pictorial showing you at the bottom how much you pay when you first start off. You have a deductible, which for most of those plans I talked about are about $325. And then as you move up in the slide, left is the before the Affordable Care Act, to the right is 2020. But the numbers start getting better for you in the donut hole. But basically, 100% during the deductible period, about 25% until you get the donut hole. And then after you get out of the donut hole, some plans you only pay 5%. We call it the catastrophic care. You finally got to that other side, and now you can pay like 5%. Some plans give you like a fixed copay. It could be $250, it could be $5, could be more depending on the type of drug you're on. But that happens after you outlay all that money in the donut hole. I'll let Dr. Capozzi take over to take questions. Thank you very much.